So, a very good morning, everyone. I welcome you all to this 6 a.m. club. So, please tell me whether I'm audible and as well as visible. Yes. Yes, Vishnu, good morning. Yes, good morning, everyone. Good morning to all of you. All right. So, once if I'm audible to everyone, then we will go ahead with the session. So, regarding this magnesium, first of all, let me just tell you the distribution of the magnesium. And before that, you also need to know how much of the magnesium is present in an individual. There is nearly around 24 grams of magnesium which is being present, right? So which is equal to almost like 2000 milliequivalents. Now, where is this magnesium distributed in the body? Right? Where is this magnesium distributed in the body? Please remember, the majority of your magnesium, it is present within the bone. Right? The majority of the magnesium, it is present in the bone. Okay. So, I said you like how many milliequivalents is present? Almost like 2000 milliequivalents of magnesium is present in the body, which is equivalent to 24 grams. Now, out of this 2000 milliequivalents, the bone, it contains almost 1060 milliequivalents. This will be the multiple choice question, right? Magnesium, it is distributed in highest quantity in the bone, followed by that muscle, soft tissue, RBC, and as well as the plasma, right? And all of them together, they constitute how much? That is 2000 milliequivalents. But what is a multiple choice question here? The highest, it is present within the bone. And magnesium, let me tell you, it is also excreted within the urine, right? It is also excreted within the urine. And this urinary magnesium, it all depends upon the serum magnesium, and it all depends upon the kidney function. See, under normal circumstances, only small quantities of magnesium is excreted in the urine, right? Only small quantities of magnesium is excreted in the urine. But for suppose when there is magnesium deficiency, what the kidneys will try to do is, kidneys will try to conserve the magnesium, right? Will try to conserve the magnesium. Okay, so urinary magnesium, it will be very negligible in case of the hypomagnesemia. And if you take the forms of magnesium, so two important questions here. The total quantity of magnesium is around 2000 milliequivalents of the entire body, or it is like 24 grams, and it is distributed in major quantity in the bone. And the urinary magnesium is also present in a normal individual, but it will be a very small quantity. You take these forms of magnesium, right? What are the forms of the magnesium which is present in our body? So we have the two important forms. One is your ionized form. The other one is the bound form. So ionized form of magnesium, it is the active form of magnesium. And this ionized form, it constitutes 67% of magnesium. Remaining 33% is the bound form, right? That means it is bound to the plasma proteins. right? It is bound to the plasma proteins. And even this 33% whatever is there, which is like the bound form, we also have not only bound to the plasma proteins, certain amount of magnesium is also bound to the phosphate, and certain amount of magnesium is also bound to sulfate. This is about the forms of magnesium. So ionized form, which is a non-bound form, there's an active form, whereas the other one is your bound form, which is bound to the plasma proteins or phosphates or the sulfates. Now, followed by that, okay, so we come across this ionized form and as well as the bound form even for some other ions as well. Can you tell me what are the other ions to which we come across this ionized form and as well as the bound form? Anyone? Very good, Ashwini. That is for calcium. So we have ionized form, which is the free form, and as well as the bound form, which is bound to your albumin. Now, the next important question is, can anyone answer this question? What is the standard assay for measurement of fractions of magnesium? Yes, what is the standard assay for measurement of the fractions of magnesium? Any one of you, please. Yes. So with the help of spectroscopy, right, with the help of spectroscopy, you will be able to divide all these fractions: ionized form, bound form. Bound form, again, the one which is bound to the plasma proteins and the one which is bound to the sulfates and as well as phosphates. Now, what is the reference range of these particular values or reference range of this magnesium when you are calculating in the serum or plasma? So the total magnesium, it is around 1.4 to 2 milliequivalents per liter, right? So that is a total magnesium, 1.4 to 2 milliequivalents per liter, or if it is like milligrams per deciliter, if it is asked, it is around 1.7 to 2.4 milligrams per deciliter. That is a total magnesium levels. Then you have the ionized form. The ionized form of the magnesium is the one which is the active form of magnesium. And how much is that? That ionized form will be 0.8 to 1.1 milliequivalents per liter. Right, 0.8 to 1.1 milliequivalents per liter. And if you take the urinary magnesium is around 5 to 15 milliequivalents per 24 hours, right? 5 to 15 milliequivalents per 24 hours. So that will be the urinary magnesium levels. So this is about, the normal values of the magnesium, right? Having thought about the normal, let me go on to the discussion of the magnesium deficiency. That is hypomagnesemia, right? See, hypomagnesemia, it is seen in almost 65% of patients in ICU. And this hypomagnesemia, it is the most underdiagnosed electrolyte abnormality. Right? This is one of the most underdiagnosed electrolyte abnormality. Now, what are the etiologies which will cause the magnesium deficiency? Right? What are the predisposing conditions? That means we will discuss the etiologies which will cause the hypomagnesemia. First and foremost, the drugs. Right? There are certain drugs which will cause the hypomagnesemia. Can anyone mention what are those drugs which will cause hypomagnesemia? Anyone? Very good, Rajeshwari. So you said thiazide diuretics. Apart from thiazide diuretics, any other group of diuretics, Rajeshwari? Very good, Vishnu. Excellent. Loop diuretics. Then followed by that, the thiazide diuretics. Any other drugs? Apart from diuretics, any other drugs? The other drugs are, we have certain antibiotics as well. Please tell me which particular group of antibiotics are active against the gram-negative organisms. Gram-negative, very good, Dileepan. That is aminoglycosides will cause hypomagnesemia. What is the drug which is used for the prophylaxis of PCP pneumonia? What is the drug which we use for the prophylaxis of pneumocystis jirovecii pneumonia? Cotrimoxazole. Apart from cotrimoxazole, come out of cotrimoxazole. Very good. Cotrimoxazole is one drug. Any other drug apart from cotrimoxazole? Very good, Vishnu. Pentamidine. Excellent. Pentamidine will cause hypomagnesemia. Okay, right. Now, please tell me one antifungal drug causing hypomagnesemia. Antifungal drug causing hypomagnesemia. Rajeshwari was telling that. Yes, Rajeshwari, what is that antifungal drug? Very good, Meenu Priya. That is amphotericin B. Right, amphotericin B. Now, one more question. There is one anti-neoplastic drug which will cause diabetes insipidus. What is that anti-neoplastic drug which will cause nephrogenic form of diabetes insipidus? And that is also the drug which will cause hypomagnesemia. Can anyone answer? Anti-neoplastic drug, not cyclophosphamide. No, demiclocycline is a tetracycline. Meenu Priya, demiclocycline is a tetracycline. I'm asking about an anti-neoplastic drug which will cause, very good, who is that? Ester Nichila. Very good, Ester Nichila. So it is your cisplatin. Very good, excellent, cisplatin. And the other drug which will cause hypomagnesemia is cyclosporine. Okay, so these are the drugs which will cause the hypomagnesemia. Now, out of which, let me discuss about the diuretic therapy. Let me discuss about the diuretic therapy. So what did I tell you? It is mainly the loop diuretics. They will cause severe hypomagnesemia. Then compared to that of, right, loop diuretics will cause hypomagnesemia. Then compared to that of the thiazide group of diuretics. Now, what these loop diuretics will do is, loop diuretics, they will inhibit sodium reabsorption. Right? It inhibits the sodium reabsorption at the level of loop of Henle. And when it is inhibiting the sodium reabsorption, this will interfere with magnesium reabsorption. Right? This will interfere with magnesium reabsorption, resulting in urinary magnesium losses. Right? Resulting in urinary magnesium losses. That is what is the mechanism of action of the loop diuretics causing the hypomagnesemia. That means it will interfere with the magnesium reabsorption. What is the site of magnesium reabsorption? What is the site of the magnesium reabsorption? Yes. Right. So that is at the level of the proximal convoluted tubule. That is at the level of proximal convoluted tubule. Okay. And even thiazide diuretics, Even thiazide diuretics, they have the similar mechanism of action. Right, even thiazide diuretics, they have similar mechanism of action. But please remember, potassium sparing diuretics, they will not cause hypomagnesemia. Right, potassium sparing diuretics will not cause hypomagnesemia. It is only the loop diuretics and as well as the thiazide diuretics. Then followed by that, I was just discussing about the antibiotic therapy. Yeah, please quickly recap. What are the antibiotics which will cause? What are the antibiotics which will cause the hypomagnesemia? Yes. Quickly, very good. Aminoglycosides. And then amphotericin B. And then pentamidine. Not cotrimoxazole, pentamidine. Pentamidine. Okay. Now you take these aminoglycosides. What these aminoglycosides will do is aminoglycosides will block the reabsorption of magnesium at now this magnesium reabsorption in the nephron, it occurs at the proximal convoluted tubule and as well as ascending limb of loop of Henle. Right, it also occurs at the ascending limb of loop of Henle. Now what these aminoglycosides will do is they will inhibit the reabsorption of magnesium at the ascending limb of loop of Henle. Okay, that is about the mechanism of action of aminoglycosides causing the hypomagnesemia. Then we have certain group of drugs used in the treatment of peptic ulcer disease causing hypomagnesemia. And what are those drugs? Can anyone answer? Can anyone answer? What are the drugs used in the treatment of peptic ulcer disease causing hypomagnesemia? The answer is proton pump inhibitors. Very good, Vishnu. Excellent. Superb, Vishnu. Proton pump inhibitors. So these proton pump inhibitors, like what is the mechanism of action? These proton pump inhibitors, they will reduce the reabsorption of magnesium across the gastrointestinal tract. Right? We will reduce the reabsorption of magnesium across the gastrointestinal tract. Okay, so that is about the peptic ulcer, the proton pump inhibitors, how they will cause the hypomagnesemia. And regarding the chemotherapeutic agents, I have just now taught you. One is cisplatin, the other one is cyclosporine. What both of these drugs do? Cisplatin and as well as cyclosporine. Both of them, they promote both of them, they promote renal magnesium excretion. Right, they promote renal magnesium excretion. Okay, this is what is the mechanism of action of cisplatin and cyclosporine causing hypomagnesemia. Then we have two important drugs, that is digoxin and as well as the epinephrine. Even this digoxin and as well as epinephrine will cause hypomagnesemia. And you know how these digoxin and as well as epinephrine will cause hypomagnesemia? These two drugs, they will cause intracellular shift of magnesium. Right, intracellular shift of magnesium. What are the drugs which will cause intracellular shift of potassium? What are the drugs which will cause the intracellular shift of potassium? Any one of you, please. Insulin, very good, Pavitra. Insulin, then beta-2 agonist, right? Insulin and as well as the beta-2 agonist, right? Hari Venkat, calcium gluconate will not reduce potassium levels. Calcium gluconate will only sensitize the cardiac cell membrane, it will not reduce the potassium levels. Please remember that. Okay, calcium gluconate will not reduce the potassium. Okay, right. So digoxin and as well as epinephrine, they will cause intracellular shift of the magnesium, right? And not only that, the alcohol, even alcohol will cause the hypomagnesemia. Now, what is the mechanism of action of alcohol causing the hypomagnesemia? See, in individuals having the alcohol abuse, right? Do they take proper food? No. So there will be generalized malnutrition. This malnutrition this malnutrition will contribute to the development of hypomagnesemia. Then chronic diarrhea will cause, chronic diarrhea can cause reduction in the magnesium reabsorption. And not only that, tell me one question here. In alcoholics, what is the vitamin deficiency the individual may develop? What is the vitamin deficiency? That is B1 deficiency, that is thymine deficiency. Now, let me discuss about the relationship between magnesium and as well as the thymine. What is the relation between these two? See, if there is magnesium deficiency, there will be also thymine deficiency as well. Now the question is why? Please remember, for conversion of thymine into thymine pyrophosphate, magnesium is required. Right? For conversion of thymine into thymine pyrophosphate, magnesium is required. So if there is magnesium deficiency, so if there is magnesium deficiency, that will promote the thymine deficiency also. That will promote the thymine deficiency also. That is about the relationship between magnesium and as well as the thymine deficiency. Please remember that magnesium deficiency will predispose to thymine deficiency, because whenever there is hypomagnesemia, thymine is not converted into its active form, that is thymine pyrophosphate. So hypomagnesemia will predispose to even thymine deficiency as well. Now, the other etiologies which will cause hypomagnesemia is the diarrhea. That is secretory diarrhea. Now, if you take this entire gastrointestinal tract, so we have the upper part of the GIT and we have the lower part of the GIT. Lower part of gastrointestinal tract, it is rich in magnesium, right? So why? Because large quantities of magnesium will be secreted into the intestines, right? Large quantity of the magnesium will be secreted into the intestines. Okay, so this magnesium which is secreted into the intestine, right? This magnesium which is secreted into the intestine will get excreted out, right? This magnesium will start getting excreted out, and that will result in the hypomagnesemia. Whereas upper gastrointestinal tract secretions, they are not rich in magnesium. They have very little magnesium. So vomiting will not cause hypomagnesemia, right? Vomiting will not cause hypomagnesemia. It is the diarrhea which will cause hypomagnesemia. Okay, and this hypomagnesemia is also seen in the diabetes mellitus. right? Also seen in diabetes mellitus. Now the question is why? Why in case of diabetes mellitus you have the hypomagnesemia? See, in which form of diabetes mellitus? It is in case of insulin dependent diabetes mellitus, right? In case of insulin dependent diabetes mellitus, you have this hypomagnesemia. And the question is why? So in diabetics, you have glycosuria, right? That is, the glucose is being excreted within the urine, right? Glucose is will get excreted within the urine. So along with the glucose, even the magnesium is also excreted, right? Along with glucose, even the magnesium is also being excreted. That is what will result in the hypomagnesemia. Okay, so along with glucose, the magnesium is also being excreted out. Now, apart from that, we also have certain cardiac conditions which will predispose to the development of hypomagnesemia. Now, what is that cardiac condition which will predispose to the development of hypomagnesemia is acute myocardial infarction, right? Acute myocardial infarction that will predispose to the development of the hypomagnesemia. Okay, right. So this is about the etiologies which will cause the hypomagnesemia. So anyone want me to do a quick recap of the etiologies causing hypomagnesemia? Shall I do a quick recap or shall I continue? A quick recap. Okay. First and foremost, like what I have discussed is the drugs. Okay. Yeah. Please tell me what are those thiazide diuretics? What are, yes, Giridhar, I will discuss about Torsades D pointers. Just give me some time. Right. Very good. So loop diuretics and as well as the thiazide diuretics. What are the antibiotics which will cause hypomagnesemia? Aminoglycosides, amphotericin B, and pentamidine. Very good. Okay. Next. Now, what are the drugs used in the treatment of congestive heart failure will cause hypomagnesemia? What are the drugs used in the treatment of? Very good. That is your digoxin. Okay. What are the anti-neoplastic drugs? What are the anti-neoplastic drugs? Very good. So that is cyclosporine and the other one is cisplatin. Cyclosporine and then cisplatin. Very good. Excellent. Now, what are the drugs used in the treatment of peptic ulcers disease which will cause hypomagnesemia? That is your proton pump inhibitors, right? Now, how does alcohol will cause hypomagnesemia? How does alcohol will cause hypomagnesemia? Right. So one, it is by malnutrition, right? And hypomagnesemia will also cause the thymine deficiency as well. And which form of diarrhea will have the hypomagnesemia? Which form of? Very good. That is secretory diarrhea, right? And how does diabetes mellitus will cause hypomagnesemia? How does diabetes mellitus will cause hypomagnesemia? Right. So that is along with glucose, that is glycosuria, the magnesium is also being excreted out, right? Next. Now, the cardiac condition which can predispose to the development of hypomagnesemia is the acute myocardial infarction. Now, let me tell you, how does this acute myocardial infarction will cause the hypomagnesemia? And you know, almost 80% of patients, right? 80% of patients with acute MI will cause the hypomagnesemia. And what exactly is the mechanism is not clear, but what has been found is in these patients with an acute MI, there is excessive release of the catecholamines. And what are the reasons for the release of catecholamines? There are multiple reasons. See, these patients with acute MI, they may develop hypotension. Once there is an hypotension, that will stimulate the baroreceptors, and that will cause the release of the catecholamines. And these catecholamines, what they will do is they will cause the intracellular shift of magnesium. Right, they will cause the intracellular shift of magnesium. So that is about the cardiac conditions which will cause hypomagnesemia. Now, let me move on to the discussion of the clinical manifestations in patients with the hypomagnesemia. So, as such, there is no specific clinical manifestations. But what has been found is, whenever there is hypomagnesemia, right? Whenever there is hypomagnesemia, what will happen to, tell me, if there is hypomagnesemia, will that lead to any endocrine abnormality? If there is hypomagnesemia, does it lead to any endocrine abnormality? You might have read that in your endocrinology. What endocrine abnormality you will come across whenever there is hypomagnesemia? So let me tell you, whenever there is hypomagnesemia, parathormone release does not occur, or there will be development of parathormone resistance. Now you tell me. So whenever there is decreased parathormone release, or whenever there is like parathormone resistance, what is the electrolyte abnormality the individual will come across? What is the electrolyte abnormality the individual will come across, right? So the individual will come across the hypocalcemia. So whenever there is hypocalcemia, there is neuromuscular excitability. Right? There is development of neuromuscular excitability. And apart from that, these individuals will also have the development of tremors. Right? They also have, whenever there is hypomagnesemia, what will happen to the QT interval? What will happen to the QT interval in the ECG? The QT interval in the ECG, it is prolonged. So when the QT interval in the ECG is prolonged, that will lead to polymorphic that will lead to polymorphic ventricular tachycardia. Okay, and this polymorphic ventricular tachycardia, if you don't treat, the individual will progress to death. Right, the individual will progress to death. And this prolonged QT interval, whatever is there, this we call it as Torsades de Pointes. And what is the drug of choice? What will be the drug of choice for this Torsades de Pointes? Magnesium sulfate. You need to give intravenous magnesium sulfate, right? 1 gram of magnesium sulfate you need to give. Okay, so that is about the clinical manifestations of the hypomagnesemia. So hypomagnesemia will lead to hypocalcemia. That is because of either because of inhibition of parathormone release or because of the resistance to the action of the parathormone. And there will be development of hypocalcemia due to which there is neuromuscular excitability or irritability, and tremors, QT prolongation, which can progress to Torsades de Pointes. And let me tell you, whenever there is hypomagnesemia, hypomagnesemia will also predispose, or it is associated with other electrolyte abnormalities. What are the other electrolyte abnormalities you will come across whenever there is hypomagnesemia? There can be hypokalemia, right? There can be hypocalcemia, right? There can be even hypophosphatemia. So these are the other electrolyte abnormalities which you will come across whenever there is the hypomagnesemia. Now, let me first discuss about the hypokalemia. Right, hypokalemia, let me tell you, it is seen in almost 40% of patients with hypomagnesemia. Right, it is seen in almost 40% of patients with hypomagnesemia. Right, this hypokalemia that accompanies magnesium depletion, right, because of magnesium depletion, if there is hypokalemia, let me tell you, if you supplement only potassium, right, if you supplement only potassium, that will not be sufficient. The individual will have refractory hypokalemia. Right, the individual will have refractory hypokalemia. Okay, but please remember what you have to do and how you have to treat this hypokalemia. This particular hypokalemia has to be treated along with magnesium. That means you have to give magnesium supplementation to the individual, and you also have to give the potassium supplementation to the individual. That is how you will treat this hypokalemia. If you treat only potassium, again the individual will come back to you with hypokalemia. So along with potassium, you also have to give the magnesium as well. Then the other electrolyte abnormality, what I have discussed, was hypocalcemia. Magnesium depletion can cause hypocalcemia. Now the question is how? Right, so whenever there is magnesium depletion, that will cause the hypocalcemia. Already I have taught you, whenever there is hypomagnesemia, that will cause impairment of parathormone release from parathyroid gland. And not only that, whenever there is hypomagnesemia, there is parathormone resistance at the end organs. Right? What are the other causes for hypoparathyroidism apart from hypomagnesemia? Yes. What are the other causes of hypoparathyroidism apart from hypomagnesemia? Hypomagnesemia is one etiology which will cause the hypoparathyroidism. Please tell me some other causes of hypoparathyroidism. I am talking about okay, very good, Raghupati. Parathyroidectomy. Good. Next. Okay, thyroid surgery. In thyroid surgery only, you will do this parathyroidectomy. Come out of it. Tell me one, genetic disorder. Tell me one genetic disorder which is associated with hypoparathyroidism. Let me see who will be the first person. Very good. So we have Gayatri answering the question first. Very good, Gayatri. That is Digeod syndrome. That is your Digeod syndrome. Gayatri, in Digeod syndrome, what is a chromosomal abnormality? What is a chromosomal abnormality? Yes, Vijay. Very good, Rajeshwari, Ashwini, Parthiban, Gayatri, Vishnu. That is chromosome number 22. Chromosome number 22. Okay, right. So yes, we'll come back to this magnesium now. So this, whenever there is hypomagnesemia, there is also hypocalcemia. And not only that, whenever there is hypomagnesemia, there can be even the hypophosphatemia as well. So this hypomagnesemia is associated with three important electrolyte abnormalities: hypokalemia, hypocalcemia, and hypophosphatemia. And regarding the clinical manifestations, just now we have discussed, that is, there will be development of the arrhythmias. Why there will be development of arrhythmias? Let me explain you. So magnesium, it is required for proper, right? Magnesium, it is required for proper function of membrane pump on cardiac cell membrane. right? Magnesium, it is required for proper functioning of membrane pump on the cardiac cell membrane. Whenever there is hypomagnesemia, right? Whenever there is hypomagnesemia, that will depolarize the cardiac cell, right? That will depolarize the cardiac cell and will promote the tachyarrhythmias. Right, will promote the tachyarrhythmias. So that is a mechanism. There is a mechanism by which the hypomagnesemia will cause the arrhythmias. Then followed by that, what is the relationship between digitalis, that is digoxin, and as well as the magnesium? So see, digitalis, that is digoxin and magnesium, both, I mean, this digitalis, what it will do is, or whenever there is magnesium deficiency, right, when there is magnesium deficiency, this magnesium deficiency will inhibit the membrane pump. And you know, even this digitalis also will inhibit the membrane pump. What is that membrane pump? What is that membrane pump? Any one of you? What is that membrane pump I am discussing about? Very good, Vishnu. That is about your sodium potassium ATPase. Right, the sodium pump, what I am talking about is sodium potassium ATPase. So whenever there is hypomagnesemia, your sodium potassium ATPase is inhibited, and upon that, if the individual is taking digitalis, that will further inhibit this sodium potassium ATPase. And you know what I want to tell you at this point is, whenever there is hypomagnesemia will precipitate digitalis toxicity. Right, hypomagnesemia will precipitate the digitalis toxicity. And whenever there is digitalis toxicity, what are the types of arrhythmias you will come across in digitalis toxicity? What are the types of arrhythmias? Right, so you will come across all types of, right, you will come across all types of arrhythmias. But in case of digitalis toxicity, please tell me, what is the most common arrhythmia? What is the most common arrhythmia? Yes. What is the most common arrhythmia? Very good, Vishnu. That is ventricular bigeminy. Right, ventricular bigeminy. So you will come across all the arrhythmias with digitalis toxicity, except what are those two exceptions? Atrial fibrillation and atrial flutter, and as well as Mobitz type 2 AV block. Right, Mobitz type 2 AV block. Okay. So this is about the digitalis and magnesium. Please remember this. Whenever there is hypomagnesemia, please don't give digoxin. I'll repeat this point again. Whenever there is hypomagnesemia, don't give digoxin. Okay. Now, what about related to potassium? Potassium and digitalis, please tell me. Hypokalemia will precipitate digitalis toxicity, or hyperkalemia will precipitate digitalis toxicity? Yes. Is it hyper or hypo which will precipitate the digitalis toxicity? It is your hyperkalemia. Hyperkalemia is the one which will precipitate the digitalis toxicity, right? Yes, very good, Gayatri. So the very good question by the Gayatri. So if we correct magnesium levels, the arrhythmias resolve. Yes, they will resolve. So you please see this point. Intravenous magnesium, right? Intravenous magnesium can abolish the refractory arrhythmias, right? Will abolish the refractory arrhythmias. Okay, please remember this is a very, very important point. Okay, next. Now, in case of hypomagnesemia, Gayatri, is your question clear? Okay, so you take the neurological findings. The neurological findings in case of the hypomagnesemia include altered mentation, the individual can also develop seizures, tremors, there can be hyperreflexia, right? Ataxia, that is loss of balance while walking. Speech, even there will be a slurred speech. There will be excessive salivation. And there can be diffuse muscle spasms. Right? There will be diffuse muscle spasms. Okay. So that is about the neurological findings which you will come across whenever there is hypomagnesemia. Coming on to the diagnosis. So how will you diagnose? Diagnosis is very simple. That is by your serum magnesium levels. Right? Serum magnesium levels. And what is a normal serum magnesium we have discussed? What is the normal serum magnesium levels? What is the normal serum magnesium levels? Yes. Yeah. So normal serum magnesium levels are 1.4 to 2.0 milliequivalents per liter. Right? 1.4 to 2.0 milliequivalents per liter. That is a normal serum magnesium levels. Right? Now, having said about the method by which you will diagnose, and the other thing is ECG. What does the ECG shows? The QT interval will be prolonged. How much is the normal QT interval? How much is the normal QT interval? Yeah, so that is around 360 to 440 milliseconds. See, understanding the concepts of ECG, diagnosing clinical emergencies regarding the ECG is very, very important part of your daily routine practice. See, we have to learn certain things, not just to write the exam, right? When we are preparing for your post-graduation entrance exams, yes, we have to read in order to crack the exam. You take the biochemistry cycles, carbohydrate metabolism, lipid metabolism, or you take protein metabolism. See, that cycles, whatever you read in your biochemistry metabolism, does they really help you for your clinical practice? Less likely, but they are very much required for you to crack the postgraduate entrance exams. But there are certain aspects of 19 subjects which are very much important, which will help us to become a good doctor. One among that is the ECG. Having a thorough concepts and identifying the clinical emergencies regarding by seeing the ECG is very important. Why? You will be able to save the lives of the patient. That important is your ECG. If the patient is having a massive anterior wall MI, and you by seeing the ECG, if you tell, it's okay, it's a normal ECG, the next 1 or 2 hours, you will be seeing the death of the patient. And the same ECG, if you have diagnosed, it's an anterior wall MI, this patient has to be thrombolized, or this patient has to be put on PCI, percutaneous coronary intervention, you know, if you save the life of a patient by seeing and diagnosing the ECG, it is like worth to the entire family. Okay, so certain things don't read for only PG entrance. Certain things in your 19 subjects you have to read for day-to-day routine practice, day-to-day life-saving strategies you have to analyze. And another important thing in the medicine is like diabetes mellitus. Diabetes mellitus, you should be completely thorough because India is a diabetic capital. You have to be completely thorough on this particular topic of diabetes mellitus also. Okay, and certain topics are there which you should not read only for PG entrance. It is for daily practice as well, routine practice as well. Okay, right. Now the serum magnesium levels and as well as the ECG are the one which will help us in diagnosing the hypomagnesemia. Now, whenever there is hypomagnesemia, magnesium replacement comes to be the very important strategy. So we have two forms. Oral forms of magnesium is there, and then the parenteral form of the magnesium is there. So if you take the importance of oral form of magnesium, the oral form of magnesium, it is for daily maintenance therapy. Right, this for daily maintenance therapy. Whereas the parenteral form of the magnesium, it is given in case of life-threatening hypomagnesemia. So in case of emergency, we correct the magnesium deficiencies by parenteral formulations. Now, what are the oral formulations and what are the parenteral formulations? The oral preparations of the magnesium, if you see, that includes magnesium chloride. It's an enteric coated tablet. Then we have magnesium oxide. Then we have magnesium gluconate tablets. Right, magnesium gluconate tablets. So these are the oral magnesium preparations: magnesium chloride, magnesium oxide, and then magnesium gluconate. Then we have the parenteral formulations as well. So the parenteral magnesium preparations, if you see, they include magnesium sulfate. Right, they include the magnesium sulfate. Okay. Yeah, yes, the magnesium sulfate orally if you give, or the magnesium formulations, they itself can cause the diarrhea, but every drug has its own side effect. Whenever there is hypomagnesemia, you have to supplement magnesium. If you don't supplement, the individual may land up in constipation. So yes, but Harini, whatever you have asked is correct. It can cause diarrhea. Now, the next important thing is, yeah, the standard intravenous magnesium preparation. Just now we were discussing, that is the magnesium sulfate. 1 gram of magnesium sulfate, 1 gram of magnesium sulfate, it has 8 milliequivalents of elemental magnesium. Right, 8 milliequivalents of elemental magnesium. Which one? 1 gram of magnesium sulfate. So, right. Yes, Harish, but it's cause. Yes, but the point is, it is not that all the individuals who with hypomagnesemia are taking digoxin, right? It is not that all the patients with hypomagnesemia are taking digoxin. Yes, if magnesium is given in patients taking digoxin, it can precipitate digoxin toxicity. But it is not always that the patient will be taking the digoxin. Yes, Harish, did I answer your question? Very good. Okay. So now coming on to the dilution. like the magnesium sulfate, it is hyperosmolar. The osmolarity of the magnesium sulfate is 4,000 milliosmoles per liter, right? 4,000 milliosmoles per liter. Okay. Yes, Harish, what do you want? I said 1 gram of magnesium sulfate, it contains 8 milliequivalents of elemental magnesium, right? It contains 8 milliequivalents of elemental magnesium. Next. So the osmolarity of your magnesium sulfate, it is high. It is like almost like 4,000 milliosmoles. It is like 4,000 milliosmoles. So you have to dilute this magnesium sulfate, right? So you have to dilute this magnesium sulfate. And always remember, for dilution, you should not use ringer lactate, right? For dilution, you should not use ringer lactate. Okay, why? Because the ringer lactate will counter the actions of infused. In ringer lactate, you have calcium. So this calcium which is present in the ringer lactate will counter the action of the infused magnesium. So that is the reason why the ringer lactate should not be used for dilution of magnesium sulfate. What do we use? The normal saline, right? For the dilution of the magnesium sulfate. And whenever there is life-threatening hypomagnesemia, right? Whenever there is life-threatening hypomagnesemia, then you have to do infusion of, right? Infusion of 2 grams of magnesium sulfate intravenously within 2 to 5 minutes, right? In infusion of 2 grams of magnesium sulfate intravenously over 2 to 5 minutes. So that is about the treatment of life-threatening hypomagnesemia. So regarding the treatment, yeah, in 100 ml saline, in 100 ml isotonic saline, right? Now, so we have oral formulations, that is for maintenance therapy. Intravenous formulations given in case of life-threatening emergencies. Oral formulations like we have magnesium oxide, magnesium chloride, and magnesium gluconate. Intravenous formulations like what we have is magnesium sulfate. And if you want the so if you take the oral preparations, magnesium chloride is Gayatri. It is 64 milligrams of elemental calcium will be there in 1 enteric coated tablet. So you need to give 1 enteric coated tablet, right? And magnesium oxide 241 milligrams. That is 400 milligrams of magnesium oxide contain 241 milligrams of elemental magnesium. And magnesium gluconate, if you see, 500 milligrams magnesium gluconate contain 27 milligrams of the elemental magnesium. And how much we require, right? We require 64 milligrams of the elemental magnesium per day. So accordingly, you can adjust the dose of the oral formulations, right? Yes, Harini, once the class is over, I will send you the PDF also. Yes, Ramya Selvaraj is asking about magnesium sulfate. How is it useful in eclampsia? Now, what did I tell you? One of the very important thing, whenever there is hypomagnesemia, the individual can develop the neuromuscular irritability. Why? The individual will develop seizures whenever there is hypomagnesemia. And whenever you give the magnesium sulfate, that will stabilize the neuronal cell membrane and thereby will reduce the neuronal irritability, and thereby it is useful in the treatment of eclampsia, right? And Ramya Selvaraj, so whenever you are giving magnesium sulfate, what is that you have to monitor? I think Dr. Ramya was teaching you recently about this. Yes, magnesium sulfate. Yes, you have to check for the deep tendon reflexes. You have to check for the knee jerk. right? What will happen to the knee jerk? Whenever you are giving excess amount of magnesium sulfate, what will happen to the knee jerk? The knee jerk will become absent. Okay, but whenever there is hypomagnesemia, there will be hyperreflexia. That is what I have taught you now, right? So if you see the neuromuscular manifestations, what did I teach you about the neuromuscular manifestations? That there will be hyperreflexia. Yeah, you can see that here. So there will be increased reflexes whenever there is hypomagnesemia. But when there is hypermagnesemia, there will be sluggish reflexes or absent reflexes, right? So that is about the treatment of the hypomagnesemia, right? And lastly, we will discuss some multiple choice questions and then we will wind up this session. Actually, in the multiple choice questions, I have the questions of both. I have the questions of hypomagnesemia and I have the questions of hypermagnesemia as well. Okay. Yes. Yeah. Please quickly answer these questions. All are the features of hyper. Please look at here. All are the features of hypermagnesemia except. Very good. So the answer is tetany. Tetany is seen in case of hypomagnesemia. And how is that? Because hypomagnesemia will cause hypocalcemia. So that is the reason why there will be development of tetany in case of hypomagnesemia. Whereas hypermagnesemia, you know, that will cause the smooth muscle relaxation in the blood vessels, causing vasodilatation. There will be hypotension in hypermagnesemia, ileus will be there, and as well as the decreased deep tendon reflexes will be there. Okay, next. Please tell me, where will you come across the heart block? Is it in hypermagnesemia? Is it in hyperphosphatemia? Both? None. Right. So very good. So heart block, it is seen in case of both hypermagnesemia and as well as the hyperphosphatemia. See, whenever there is hyperphosphatemia, this phosphate will combine with calcium, resulting in the calcium phosphate. This calcium phosphate, it will get deposited, right? It will get deposited in the conducting tissue of the heart. So once it is deposited in the conducting tissue of the heart, that will result in the heart block. Okay. And your hypermagnesemia and hypomagnesemia, both of them, they can cause the heart block. But in fact, hypomagnesemia will cause polymorphic ventricular tachycardia, but hypermagnesemia will cause the heart block. Okay. So both of them will cause the heart block. Which of the following is not a cause of the hypomagnesemia? Which of the following is not a cause of the hypomagnesemia? Very good, Ramya Selvaraj. The answer is rhabdomyolysis. The answer is rhabdomyolysis. Rhabdomyolysis, you know, in fact, there will be hypermagnesemia. Gentleman syndrome, yes, there will be hypomagnesemia. Gentleman syndrome, where exactly is the problem? The defect is at the level of distal convoluted tubule. Okay, so there will be hypomagnesemia. Magnesium reabsorption does not occur. Whereas, what do you understand by this word? Refeeding syndrome. Refeeding syndrome, it is seen with starvation, right? Provision of nutrition in the form of substrates will lead to cellular consumption, leading to rapid shift of magnesium from extracellular compartment to the intracellular compartment. So those individuals who have undergone starvation for a long period of time, and the provision of the nutrition in the form of substrates will cause the cellular consumption, leading to rapid shift of magnesium from extracellular to the intracellular compartment. And even your hyperaldosteronism, right? So hyperaldosteronism will lead to expansion of the plasma volume and resultant fall in the magnesium. Because whenever there is hyperaldosteronism, there is more and more sodium and water reabsorption. So once there is more and more sodium and water reabsorption, that will expand the plasma volume and will dilute the magnesium, and that will result in the fall in magnesium. Okay, next. Whereas rhabdomyolysis, there will be destruction of the muscle cell, and there will be release of magnesium causing hypermagnesemia but not hypomagnesemia. So that is the reason why, what is the answer to this question? Not a cause of hypomagnesemia. The answer is rhabdomyolysis. The answer is rhabdomyolysis. Okay. Right. So all are the indicators of hypermagnesemia except, right? All are the indicators of hypermagnesemia except hypermagnesemia, there will be decreased deep tendon reflexes. This is a true statement. And hypermagnesemia, there will be smooth muscle relaxation causing vasodilatation. Decreased blood pressure will be there. And there will be also heart block. But main D, acute will not be there, right? So can anyone tell me what is this? What is this main D acute? Yes, quickly. See, this main D acute, very good. Who is that? Raksana Fatima. Very good, Raksana Fatima. Main D acute is nothing but your obstetric hand. It is nothing but obstetric hand in delivering a baby, which is nothing but your carpopedal spasm. So where will you come across this? Will you come across this in hypomagnesemia or hypermagnesemia? Yes, you will come across this in hypo or hyper. You will come across this in hypo. Okay, next. You see another question. Which of the following is not seen in hypermagnesemia? Which of the following is not seen in hypermagnesemia? So in hypermagnesemia, the one which you will not see is the T-wave inversion. Bradycardia will be there, heart block will be there. And QT prolongation, it is seen in both hypomagnesemia and as well as the hypermagnesemia. And dilated pupil also you will come across, but T-wave inversions, they are not the features of the hypermagnesemia. Please remember, that's an important point. Many of you are answering QT prolongation, but QT prolongation, yes, it is commonly seen in with hypermagnesemia. But occasionally, even with hypermagnesemia, you can have this particular QT prolongation. Okay. Now, last question, and then we will wind up. Yes. Incorrect about the hypomagnesemia. Incorrect about the hypomagnesemia. Very good. Who is that? Ramya Selvaraj, Rajeshwari, Raksana Fatima. Good. Intramuscular magnesium sulfate should not be given. It is intravenous magnesium sulfate. And hypomagnesemia will cause tetany, will cause resistance to parathormone, and will also cause the arrhythmia. But intramuscular magnesium sulfate will not, it is not the route of administration of magnesium sulfate. Okay. So that completes the discussion of your magnesium. So in the previous two sessions, I have discussed hyper and hypokalemia. This session is both your hypo majority and little about hypermagnesemia as well, right? So this completes the discussion of the disorders related to your magnesium. Now let me just upload the file. Yes, yes, Vijay Satyanarayanan is asking how decrease in phosphate occurs in the hypomagnesemia. See, yeah, so whenever there is hypomagnesemia, hypomagnesemia will inhibit the phosphate reabsorption from the tubules, right? hypomagnesemia will inhibit the phosphate reabsorption from the tubules, and that will result in the hypophosphatemia, right? Okay, let me just upload the file and please tell me how was the session. So were you comfortable? Was there any difficulty? Next class, when is the next class? I'll just speak to Arun because I'm supposed to do one important topic, that is renal transplantation. Actually, I have done renal replacement therapy. Dialysis part I have discussed. Renal transplantation he has asked me to do. So I will just ask him and then schedule the class. Okay. Right. So meanwhile, I'll just upload the PDF for you. So you can all download and please revise. And yes, I have just uploaded the PDF to your chat. So please go through this and definitely it will be useful for your upcoming entrance exam. Okay. It is like you should download it today and you have to read it today only. Then only you can remember. If you download it today and read it after 1 week, and everything will become completely new for you. Okay. So please download it and please revise it. Okay. Renal replacement therapy PDF. Okay. 1 second, Gayatri. I am uploading even your renal replacement therapy. I think I have sent